Welcome back to AGIC, Science into Practice, the podcast that pulls back the curtain on infection prevention with just the right mix of science and sass. And can someone please give us more FTEs? I'm Nikki, and with me as always is my co-host, an IP powerhouse of Dartmouth Health, the APIC president-elect. Actually, she's the current president, and someone who, frankly, has zero ability to chill, Jess Swain.
I have some chill. I chilled for 14 minutes last Sunday, Nikki.
Well, that's adorable. So today we are joined by none other than Jess Swain. Yes, the very same. And Dr. Brenna Doran, who authored the recent AGIC article, Quantifying the Progressing Landscape of Infection Preventionists, a survey-based analysis of workload and resource needs. And before we dive in, I'm going to take a second to introduce our guests. First up, someone who already sounds suspiciously familiar, my co-host, the one and only Jessica Swain. Jess holds an MBA. She's a certified medical laboratory technician through ASCP. She's board certified in infection control, and she's an Institute for Healthcare Improvement Fellow, because of course she is. She started her career in the Dartmouth Hitchcock Labs back in 2007, getting deep into microbiology, anatomic pathology, and transfusion medicine before making the fateful and noble leap into infection prevention in 2015. Since then, she's been promoted not only once, but twice, and now serves as the System Director of Infection Prevention and Control for Dartmouth Health. She is deeply involved in APIC at both the local and national level, currently serving as her chapter president. She's held leadership roles on the New England chapter board, served on the editorial panel for Prevention Strategist, and is also one of the voices behind Dartmouth Health's own podcast, The Cure. Oh, and she also co-hosts this podcast, in case you hadn't noticed. So basically, she's everywhere. She's doing everything. And she's still somehow replying to emails faster than I can finish my coffee. And also joining us today is our guest, Dr. Brenna Doran, a true infection prevention unicorn. You have asked me to call you Brenna, so I will. Brenna is an infectious disease epidemiologist with over 20 years of experience in the biological sciences, including more than a decade in infection prevention and another 8 years as a clinical microbiologist. She's also a certified career and wellness coach, which means she not only knows the science, she knows how to help you survive it. She's the founder and CEO of Innovative Partners Institute, where she offers leadership coaching for infection preventionists and consulting in infection prevention and biodefense. And if that weren't enough, she volunteers on APIC's National Professional Development Committee, serves on the editorial panel for Infection Control Today, and co-writes the monthly IP Lifeline column. She's written on everything from COVID to burnout to staffing strategies, and let's just say when Brenna writes, we read. So if you're thinking, wow, these two sound like the dream team, you're absolutely correct. So let's get into it.
Thank you so much for the warm welcome. And I was really excited to have an opportunity to work with Jess on this project. And I'm excited to talk about it. And also, I think it's just a beautiful kind of opportunity where Jess and I had a conversation that turned into not only this fabulous project, but also a manuscript. So thank you for the opportunity to share a little bit more about it with Jess.
It's fabulous. I'm so excited to have you guys on here. And Jess, now that you're on both sides of the mic, how are you feeling? You feeling a little weird, a little powerful?
It's a little bit of both, but mostly I'm wondering how many jokes you're going to make at my expense.
Oh, not nearly enough. Let's jump in. Okay, so first up, this study was a big one. 91 acute care facilities surveyed, and the results weren't exactly a surprise for those of us living it, but they were staggering. Over 59% of infection preventionists are working more than 40 hours a week. That is not sustainable. So let's start with the basics. Why does infection prevention still feel so understaffed in 2025, even after COVID taught us how vital this role is?
I think one of the things as Brenna and I were working on this project that we talked a lot about were all of the additional things that infection preventionists had started taking on as COVID came about. and how they had kind of this hand in everything from across all different departments that maybe they hadn't necessarily interacted in before. And so I think, after COVID ended, we talked about how infection preventionists weren't necessarily then able to pull themselves back out of those additional responsibilities that they had taken on. They just kind of became the normal. So, the FTEs didn't change, but the responsibilities grew. And Brenna, do you want to add to that?
I think I think you nailed it. I think the other piece is we were still kind of reeling from COVID, and there was kind of this immediate shift to return to HAIs. So not only were we still pretty neck deep in all of the COVID work, managing isolations, managing patient throughput, but then also there was this immediate pivot to focus on HAIs and pick up all the work that we were doing pre-COVID. And so we were, our cup was running over with work, and we were trying to juggle it all. And at the time, our administration didn't understand what that looked like. What does more mean? And so unfortunately, I think at the time they thought because we could handle it all, that we could handle a little bit more. That kind of led, I think, a little bit to our current state.
So one of the most interesting things to me in the data that was that geographical spread. We noticed that IPs in the West were logging the longest hours, 44.9 on average. While in the Northeast, it was a little bit less than that. It was 41.6. So Brenna, how do you think the geography may affect how many hours the IPs are working? Do you think it's harder to be an IP in the West, or are you guys just overachievers?
We're all overachievers, and mine is definitely not geographically based. I know you and I spent some time kind of like musing on what this is and what's causing it. And I think one of the things that kind of came up is, there are more regulatory, I think, obligations in California than there are in some other parts of the country. Also, we talked a little bit about the construction. So something that's unique, at least to California, is that everything needs to be earthquake proof by 2030. And so what we found through this process is a lot of our older hospitals, it costs more to actually do renovations than it does to bring them down and build new towers. So a lot of IPs in California are spending quite a bit of time around building new towers, ensuring things are, earthquake proof. And then also, I think like other parts of the country, there's a lot of expansion going on. So I think that those are probably two factors. I assume there's probably many more that you and I, maybe weren't able to kind of think up. But I would love to see a little bit more research and exploration into what that is and why it's happening.
It's interesting. I wonder if that's going to kind of spread across the country, that need for update, and California will be the leaders, the mentors in that. Okay, so I'm going to ask the dream question now. Both of you, close your eyes, unless you're driving. Okay, so what would infection prevention actually look like if IPs had the staffing and support they needed? Like, would we finally get to sleep through the night and meetings would end on time or early, and we'd get to use the bathroom without our phones going off? What's it look like?
In my mind, I always say, you can have the minimal number of infection preventionists, but that means that you're going to be doing the bare minimum for your program, right? So one of the things that I have always said is that if you have the minimal number of staff, the minimal number of infection preventionists, then your program is going to only be able to handle the minimum amount of tasks. And there are certain things in the IP world that are required, like reporting to NHSN, so participating in surveillance, and some education to your staff. But some of those other things that we talked about that came about during COVID, being more involved in some of these other departments and really providing more critical education around PPE, and to Brenna's point, providing that insight into construction and renovation around infection prevention. Some of those things might fall to the wayside when you have that minimal number of staff. So in my mind, what infection prevention would look like if you had the appropriate IP staffing to support really all of the needs of the program, is that yes, we would be able to sleep at night. We wouldn't be thinking about something that we missed, or, oh, I forgot to respond to that email, or am I going to get paged overnight, or, just any number of things, because we know it's able to be handled during your regularly scheduled working hours. Thoughts, Brenna?
I think that was super profound how you kind of ended that, this concept of actually finding an endpoint in your day and being able to go home. When this question was asked, what first came up for me is really this concept of prevention. So I feel like infection preventionists, we go into the field, what we're most passionate about is preventing infections. However, because of staffing and all of the, responsibilities and obligations that we need to meet, we spend so much of our time, I think, kind of reactively, right? We're doing surveillance to identify infections that have already occurred. What I would like to see for infection preventionists is an opportunity to really live in that proactive, preventative space. And so what that might look like is, instead of spending time doing hand hygiene observations and collecting data, that we have time to educate on the floor, provide on-the-spot coaching, provide support, that we're, being able to work with our units and looking at, central lines and really looking at ways that we can improve things, really working, hand in hand with our frontline staff, with our partners, with our stakeholders, in a way that really supports the work and patient safety. Whereas now it feels like we're always trying to run and catch up to something that's already occurred. And I'll be honest, as an IP, that's just not as satisfying. Like, we want to prevent things. We want to help people.
Mm-hmm. I agree with that. And I think we're all trying to do that to some degree. So that's why we have secret hand hygiene observers, and we're always looking for ways to improve our hand hygiene program. I think part of that, there's a tug of war on what infection preventionists define their role as versus what administration, leadership, and everything trickling down from that defines our role. So let's take wound care nurses, for example. The wound care nurse is there on the floor to teach the patients. They are the subject matter expert. They are who you go to for education. They're not there 24/7. They're not there to do 24/7 care. They're not there to turn the patients every 2 hours. That's the bedside practitioner's job, is to make sure all of that is done. Similarly, as the infection preventionist, I think we're trying to get to a model where to wash your hands and to put on your PPE. We should not be there to have to audit that all the time. That should not be our role. We should be looking at research on how the latest research on how to prevent CODIs and CLABSIs.
I think what you're saying is that we have these foundational practices that are what we would consider low-hanging fruit, easy, something that, you shouldn't really need to be re-educated on. But what we find ourselves doing is we find ourselves observing that these practices aren't actually happening, and then having to spend time providing re-education or auditing and giving that feedback, when we could be spending our time working on process improvement projects and implementing things that have a larger impact on those HAIs.
Add to that a little bit.
Yes, please do.
I feel like, part of the topic you're talking about is gonna raise some people's hackles, but I feel like the underlying premise is that we do not want to be enforcers. We do not want to live in a space where our job is to point out what's wrong, and enforce policies. We want to live in a space where we are able to provide, SME support, help marry, best practices with what's actually happening on the units, and be a supportive presence. We want people to look forward to having us in their units.
One of my mentors said that we're the informers, not the enforcers.
Yes.
Well, so let's get nerdy.
I'm always down to get nerdy.
Yeah, what I mean by that is, let's talk the technical stuff. So one of the biggest statistical takeaways was the association between the inpatient bed count and the infection prevention FTEs. And honestly, Brenna and I went around and around, and we looked at the data in probably every possible way that you could. But this was one of the things that we spent a lot of time looking at as well. So Brenna, can you talk a little bit about what that association means and what do you think it's telling us about how we're doing with the staffing benchmarks across different hospital sizes?
That's a really great question. And I know you and I spent a lot of time just kind of talking through this. So what kind of came up for us, I think, together is that each infection control program is a little bit unique from facility to facility. Even if you have two facilities of the same size, they might be doing slightly different things. And so we kind of noticed that, looking at our own organizations and organizations we had worked at. So one of our thoughts here is that, whereas there are some regulatory requirements, how hospitals choose about going about those and what other additional projects or initiatives that they're involved in can really vary. And so really what we were really kind of trying to understand is we did see some, again, statistical significance around bed counts, but we also found, we did not find some statistical significance in areas that we thought we would, such as the complexity of the hospital. And so I think, again, that kind of leads us to the fact that there's a lot more nuance here than which you can readily put into a box. And we learned that a little bit more when we asked some of the questions we did in our study, just trying to understand how the staff moved through their work, right? How did they support other departments and how did other departments support them?
Jess, do you have anything you want to add on to that?
No, I think that's perfect.
Yeah, I agree. I think that's a concise, cool answer. And another thing that stood out, there were regional differences in how many hours IPs work, but no significant differences in median FTEs by region. And I thought that seemed like a red flag. Am I right about that? Like what are the implications of that discrepancy? Same staffing, different workload?
So I think that's a great question. And the PhD in me is going to say that I don't feel like we had a large enough sample size to really dive into that. And so while our study does have some interesting findings, our sample size overall was 91 across the US. And so I would love to see a larger study, dive into a little bit more just to see whether or not they're seeing the same thing and to provide a little bit more context. But with that said, it really doesn't surprise me, again, in talking to other IPs in different parts of the country. There are different kind of expectations and different staffing models and different levels of support that different areas and different hospitals have that do not seem to be universal. So one major example of that, in Jess and I talking, is that she said they have, a hospital epidemiologist. We don't have that on the West Coast. On the West Coast, we have an ID doctor who is, perhaps the hospital epidemiologist. But that person is not actively involved in the work, which again kind of led to, how are different IP programs supported and how do they support? So I will say that all these beautiful conversations that Jess and I had really provided us an opportunity to look at this survey in a really novel way. And I think, again, really kind of identify some interesting things that have not been identified in other research studies.
We laughed, we cried.
Laughed and cried some more.
Let's talk a little tough love here about the staffing calculators. Actually, Brenna and I talked a lot about this too, because as we're talking about FTEs, staffing calculators were available for use. And so, that was kind of incorporated in this conversation and what the future of those staffing calculators might look like. So, Brenna, do you want to talk about some of the limitations that we discussed of the current calculators and how maybe new calculators or AI might actually help fix this? Like, do we need a ChatGPT to do our staffing models now? Actually, we should try that.
So yeah, I kind of love the idea. I'm really curious to see what they come up with, and maybe one of the listeners will actually try that and let us know what they find. I think that'd be a fun exercise. Yeah, I think when we were really talking about this, again, we kept talking about just the complexities with our own organization. And I think that the challenge, which we've kind of already alluded to, is that each facility, each organization, each system kind of has their own unique IP program. And whereas there might be some really basic tenets of it, how much time they spend, the depth that they do it can vary. So just a real simple example is, some hospitals only look at hysterectomies and colon surgeries for their SSI surveillance. Whereas there's other hospitals that look at all of their SSIs, both inpatient and outpatient. And so just that one singular example, you could see just the range of time that might take. And then if you want to go and add that, depending on the size of the hospital. So speaking to limitations, I think that the current staffing calculators have, made leaps and bounds improvements over, 100 licensed beds to one IP or 69 licensed beds or 69 beds to an IP. And so I think we're moving in the right direction. But when you're trying to come up with a staffing calculator that really kind of works for everybody, that's generalizable across, healthcare models, across systems, there's going to be some limitations. And so I feel like, again, the staffing model has given us a really great leap forward. It's giving us more information, more data to kind of help us understand how hospitals are operating and help us understand how, what they're receiving as recommendations, how does that work for them in practice. But again, those limitations are that it doesn't have all the nuance, nor does it have the ability to scale up or scale down. So one of the things that Jess and I talked about is, summer, we work on our policies, we work on our plans. Sometimes we get to go on vacation. Sometimes we get to work on our tan. But come respiratory season, none of those things are happening. And that's where we work a bulk of our time. And so how do you ramp up from a staffing perspective if everyone on your team is working, 50, 60 hours a week? So again, I think there's some opportunities there. As far as next steps, I think in an ideal space, again, continue working on that staffing calculator and refine it. But then ultimately leveraging some sort of a machine learning or AI model to really provide an opportunity for individual hospitals to add those, kind of niche, those really facility level nuances to provide an actual FT output that works for that individual program. I think we all know it's really hard to say that you need one person per this and have that work universally across. And I think as an IP, it's super important that if our administration wants us to do more, as we did after COVID, we need a clear, concise way to articulate what that work looks like and for our administration to understand how that request turns into time and how that time turns into FTEs in a way that we can get their buy-in on.
Indeed. And that kind of ties into what I was trying to say earlier. What we define our role as might be a little different than what administration understands our role to be. And it's a very important subject, a very important topic. It's very engaging. And I wanted to point out, you also found something interesting in the qualitative side of the survey. So the whole who supports who question, in a lot of settings, IPs are lending support to quality, risk, antimicrobial stewardship. Sometimes they are performing those roles, but they're not always getting that support back. So can you talk about what this sharing of roles and support looks like across different facility types and what the trade-offs are?
I mean, I think we did look at this. We looked at, do they have a hospital epidemiologist? Are they supporting central sterile reprocessing or, some of these other departments that you mentioned? And I think, in some ways, when you have a dedicated analyst or something like that, that's great. And that takes some of that load off the infection prevention program and infection preventionists to do some of that work. I think in some of the other cases that may then contribute to, well, we need less people because they have this external support for their department. And we also sort of looked at how this support was budgeted. Were they part of the infection prevention local budget, or were they paid for by a budget outside of infection prevention? Brenna, do you want to say any more about that?
Yeah, no, I think that again, like Jess and I had so many great conversations that kind of led ultimately to the study and the survey questions. But again, something that kind of came up is, when I was system director at UCSF, we had a team of analysts and a team of IPs that performed the HAI surveillance for, our hospitals. And then we also had a data analytic team that was able to come up with just beautiful, elegant, just remarkable data analytics and dashboards. We also were able to, work closely with our antimicrobial stewardship. So not only did we have internal resources, again, specialized, that allowed us to really hone our time and our efforts, but we also did support some other units. such as our ambulatory care. And so again, I think this back and forth is not only helpful from a budgeting FTE perspective, but it's also helpful to recognize that, IPs wear so many hats, and IPs are incredibly versatile, and we are, willing and able to take on new skills. However, it's not realistic or feasible for us to be a subject matter expert in everything. And so I think by being able to really leverage other departments, whether you're paying for the FTE or there's some sort of shared space, to really leverage other people's skill set, I think it really kind of alleviates some of the strain on the IPs and really enhances the overall IP program. Also, because both Jess and I worked, in larger academic hospitals, it also provides IPs an opportunity to specialize. So if you're, a solo IP in a small hospital, then you are doing everything. There probably isn't a lot of opportunity for you to really work with other departments or, for that resource sharing. However, in larger hospitals, because there is such, wider range of services being offered, some of the patient demographics are more complex, there is an opportunity to specialize. And we think that, as IPs think about their career trajectory, what brings them joy, having an understanding that there are other ways to practice infection prevention was also really important to share with the larger audience.
It's funny that you mentioned the ability to specialize in those larger hospitals, because I just had that conversation this morning. That's funny.
That's well said. What some sort of specialties do you have in mind?
So, for instance, at the Academic Medical Center at Dartmouth, the infection preventionists have the opportunity to be the CAUTI lead or the CLABSI lead or the carry-op lead, but there's also the ability to have a focus in endoscopy or central sterile reprocessing. So and even construction and renovation, because again, to Brenna's point, lots of construction and renovation happening all the time, or even around, it's an old building, so water leaks and things like that. So I think that's a big difference between our academic medical center and our community hospitals and critical access hospitals, is that those critical access hospital IPs and the community hospital IPs have less of that ability to specialize, because they are doing all the things.
Everything. Yeah.
Right.
They're specializing in everything.
Exactly. Yep. So we also saw that acute care hospitals with integrated services had the most collaboration and cross support. And that sounds great on paper, but I've been in those shoes, and sometimes that support just means more meetings. And I think, I don't know if y'all know this, but I really hate meetings. Brenna, what's the balance between collaboration and just being over leveraged?
I love that question. I think as an IP leader, that is a space you kind of continuously, consistently, habitually inhabit. And what always came up for me is kind of a nice barometer or litmus test is whether or not our involvement was adding value. So are we helping to clarify things, refine things, or are we adding more chaos? Also, I think there's also an opportunity for us to sit in, as an SME, there is a request, we provide recommendations, and then we allow, the broader team to move forward with those efforts, and we can consult. So I think, kind of the earlier conversations, really identifying what your role is, what you see yourself contributing to a project, ensuring that there's a shared understanding of what your role is and what you're contributing to a project in advance. I think that really helps. And also just being really clear what your boundaries are. So for example, my team would be absolutely open to starting a policy, finishing a policy, doing all the revisions, talking to everybody, doing the lit search, because they're IPs and they're amazing and that's what we do. However, it doesn't make sense for us to maybe do all those pieces. It may make more sense from an SME perspective for us to provide that infection prevention lens on the policy and then allow other people, again, who own that policy to continue that work.
So the catheter usage policy is not dictated by infection prevention. That's dictated by nursing with infection prevention input.
And again, it's not that we're going to show up for 30 minutes and go on about our day. But I don't know if we necessarily need to be there for, multiple meetings and iterations over the wording or on sections that do not have an infection prevention focus.
Right.
And really, it's really about kind of being more efficient and also really kind of being in spaces where we add value. Because to Jess's point, I don't know an IP that loves meetings. And if we can minimize those, but maximize our contribution in the way that we're able to support others, I feel like we can all agree that's an easy win-win.
Yeah.
You're right. I do agree. And I bet you're right. I bet all our listeners agree as well. And I could talk forever about this. Jess knows that we can talk for hours about a subject, but I think it's probably important that we break it down to two big takeaways for our listeners. So let me do a couple of insights that I took away. So first insight was that staffing ratios still a mess. One size fits all doesn't work when your hospital is 100 beds in the woods versus 1,500 beds in the metro area. And second insight, we're still wearing way too many hats. IP, quality officer, outbreak manager, educator, therapist sometimes. So how do we fix that? Or at least make sure that our IPs don't burn out in the process? We've had so many conversations around this.
I think Brenna highlighted something in the last question, which is, we need to set boundaries and help others, including the C-suite, understand where we're adding value and where those boundaries lie. What should infection preventionists indeed be doing?
Yeah, I would
I know.
agree
What
with
about
that.
you? Yeah. Take it away.
I feel like there's definitely an opportunity for shared understanding. And I think you hit on it, Nikki, kind of at the beginning of the conversation, where there is kind of this ongoing disconnect between what administration thinks we do and what we think we do. And I think that is an opportunity for us to really kind of clarify and create a shared understanding. Because the reality is whereas, administration may not want to fund us for our ability to handle outbreaks or exposures, I guarantee you, once we start having measles outbreaks and measles exposures, they're going to want us there running lead on those. And so I think that not only is really understanding where IPs need to be, what work do we need to be focusing on, but also, again, kind of understanding that ramp up or ramp down. And so, again, what I mean by that is infection prevention, is a little bit of feast or famine, or mostly feast. But I mean, we can all make the joke that we walk into our office at 7, 8 o'clock in the morning, we have a plan for the day, and 30 minutes in, it's gone sideways. So we really do have to be able to pivot, to be flexible, to show up and attend whatever emergent or priority situation is occurring. But conversely, we also need an opportunity to sit down and do surveillance and to make sure our patients are on the right isolation and to make sure our policies are up to date. So I think there's really just an opportunity to have balance. And then when it comes to, too many hats, again, I think that's where there's an opportunity to really leverage into, our different departments. So even if you are a lone IP, there's a great opportunity to make friends with your facilities. There's a wealth of information there. Working with your employee health department to figure out how you guys can tag team, if there's some, staff exposures so that you're communicating. There's an opportunity to, find some nurses that are passionate about infection prevention and bend their ear. So I think there's lots of opportunities to really leverage relationships and to build an infection prevention program that's bigger than one person, that I'm hoping that we can also move towards.
And before we close out, we always like to ask a reflective question. So here's today's. What would our profession look like if infection prevention wasn't about surviving, but thriving? If we were resourced, supported, and actually recognized for the full scope of the work that we're doing?
I love that question for a few reasons. One, I'm very passionate about, IP burnout. I've been focusing a lot of my research efforts in the space, but I'm also working with National APEC and an IP attrition study. And what we're finding is IPs are leaving the field. And so we're trying to actively understand why they're leaving the field. And so I think in answer to your question, ideally, the focus wouldn't be what makes IPs want to leave the field, but what can we do to help ensure that all of the people that want to become IPs that are remaining in the field until retirement, are able to practice at their highest level. So I'd really love to focus, on the positive side instead of really what's going on. And I think more largely is how do we better support each other? What can National APEC do to support the IP field? And then how do we, learn to be better leaders to support our IPs during, really some chaotic and stressful and tenuous times.
Guys, Brenna, Jess, both of you, I really want to thank you for this work. It's essential. You're advocating with data and nuance. And I'd also like to say, Jess, I let you off really easy today.
Well, I think Brenna is so articulate that I'm super glad that she was here to help answer these questions.
She is. Brenna, I really appreciate you being on here. You are very articulate, really help shine a light on something, but really help us understand it. Because like I said, there's a lot of data and it is nuanced. So I think you really helped paint a very clear picture.
Thank you very much for the opportunity to share it. And again, this all started with a conversation. So other IPs that are out there, connecting with other IPs, having these fabulous conversations. This is kind of a shout out to you to think about how do you take that conversation, that question that we would all love to hear more about, and turn it into a research study and share that answer, those findings with the rest of IPs.
Absolutely. So thanks to everyone for listening. Keep doing that hard work. Keep asking for what you need. And remember, it's not heroic to burn out. It's strategic to staff up. Until next time, wash your hands and watch your hours.
And that's a wrap. Thank you for joining us today. We are Nikki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and Audio Tech's Blake Althen and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.